it gives me great pleasure to introduce a colleague of mine from the IUA, Dr. Lisa Keating, who's the Director of Research and Innovation at the IUA, the Irish Universities Association. And she works with the Vice Presidents and Deans of Irish Universities to advance Irish research and innovation. She also plays quite a significant role in Campus Engage, which is dedicated to promoting civic and community engagement across all the university's portfolio of teaching, learning and research. And for those who've opened up the little PDF that was put in the chat function, you'll see that Lisa has a fabulous bio, and some of the things I thought I knew about Lisa, I don't know. And Lisa is actually an industrial, has a BSc in industrial microbiology and is a microbial biochemist. And I did not know that, Lisa. And you've got extensive experience in the UK and extensive experience working in Enterprise Ireland here when you returned to Ireland before you took up your position in the IUA. So it gives me great pleasure to hand over to Lisa, who is chairing this session looking at the impact of the crisis on the people in research here in Ireland. Thanks, Lisa.
Thanks, Mark. And yeah, I'm delighted to be here. And thanks for the very, very kind introduction. Yes, my microbiology and infectious diseases are very long behind me now, but they're obviously a topic that everybody's very interested in at the moment. So I'm delighted to be taking part in today's event and chairing the panel. We have an exciting group of people talking to us today. And I think it's really, really important for the Irish Health Research Forum to provide this place for this open dialogue. So I'm delighted to be part of it, and I'm looking forward to the session. As Avril and yourself have mentioned, the COVID crisis has seriously disrupted life in Ireland and around the globe. And it's really changing the world that we live in daily if we're listening to the news and on Taoiseach yesterday. So it's just changing all the time. But for me, it was really, really heartening to see how researchers across the Irish system self-galvanised into immediate action. And that's continued over the last nearly 2 years. I mean, it really is heartwarming to see that. So I know that there's an awful lot of challenges that are out there, but I think that community spirit that came together was really great. And they worked together towards the issues and problems that we face. But you have to remember that researchers themselves were also really affected by the pandemic in both their professional and personal lives, as Avril has mentioned. The COVID crisis, it disrupted research activity, whether it was in laboratories or facilities or archives or, field sites, or not to mention the challenge of working with patients and the public. So that's been really difficult. But on top of that, researchers, like all of us, were faced with school closures and care and responsibilities, and they needed to be able to juggle their work commitments with their family duties. So it's been a really, really tough time. And today, with today's 3 panel speakers in this first session, we're going to learn about the impact of the crisis on the people in research through a number of different lenses. And I think it's important that to note as well, as Avril and Mark have both said, that while there's been a lot of negatives, there are some positives that have come out of the pandemic. And I think one of those is really about raising the awareness of the value of research. I don't think it's really ever had the spotlight that it currently has shining on it now. And the public are engaging, and it's a real opportunity to, one, show the public what's out there, but also to get their input into research to make it stronger. So again, just echoing Avril's comments about creating our future, the Irish government initiative that SFI is supporting them with. I think that's a really, really important initiative. I believe they're at 8,000 submissions and hoping to get to 10, but it's not about the numbers. That's a great way to measure the level of engagement. But I think what's really important is researchers and people out there talking to the public, talking to different end users of research and really understanding. So I'm looking forward to Seamus's brainstorm. It's 10 minutes. I've already done one of those before and I found it really, really helpful and engaging, and I was glad to be part of it. So I hope everybody stays tuned in for that as well. We have a great morning ahead. But I shall stop talking and I'd like to introduce our first speaker, Carole Schilling. Carole is chair of the Irish Research Nurses and Midwives Network. Originally from the UK, Carole has a BSc in nursing in 1993, and she worked as an intensive care nurse for 5 years before changing into a cardiology research sister. In 1999, Carole completed an MSc in nursing, and she moved to Ireland in 2001. And since then, she's gained further research experience in various clinical settings in the pharma industry as a clinical research associate. And she's also worked across a broad range of therapeutic areas, including respiratory, infectious diseases, hepatology, oncology, and ophthalmology. In 2012, Carole joined the RCSI Clinical Research Centre as a senior clinical research nurse, and in 2013, she completed a level 9 postgraduate certificate in nursing clinical research. She took on the newly established role of RCSI Quality and Regulatory Affairs Manager in 2015, and in November 18 became the project manager for the Irish Research Nurses and Midwives Network, the work for a survey entitled Count Me In. So Carole works part-time as a study coordinator at Beaumont Hospital, as well as chair of the Irish Research Nurses and Midwives Network. So over to you, Carole.
Thank you for the introduction, Lisa, and thank you, Avril, for asking me to join the panel this morning. As Lisa said, I'm here in my role as chair for the Irish Research Nurses and Midwives Network, but I also work as a research nurse in a large Dublin hospital. So this is also very much the first-hand experience, but I think it's experience that's shared across the board with research nurses nationally. Now, I know the brief from Avril was to discuss the impact of COVID and the cyber attack on clinical research nurses, but I know they also want a positive spin on it. So, I mean, what I've done, the role of the research nurse is varied. We know from previous research that the role is dependent on the type of research and the location of the research and other members of the research team. So really, I just want to go through the day-to-day role of the research nurse and how it's been impacted by COVID and the cyber attack, and also just how we, as research nurses, have been able to think outside the box to actually implement changes. So hopefully that'll be a positive aspect. So I suppose when in end of March 2020, when the first wave of COVID hit us, I suppose research nurses, like all other healthcare workers, were, I suppose, stunned and kind of, not knowing where to go and what to do in terms of how to manage clinical trials. And I suppose one of the biggest challenges that we face was the retention and monitoring of clinical trial patients that we had currently on our studies. Now, depending on the nature of the study or the patient population, some of these patients would have been classed as high risk. They could have been on immunosuppressant drugs. They could have been part of the elderly population. They could have had other chronic health conditions, asthma, diabetes. So these patients were required to self-isolate. So really, there was no way we could expect these patients to come into the hospital. But certainly, as a clinical research site, our responsibility is to have close monitoring of clinical trial patients whilst they're on drugs, on study medication. So wherever possible, we had to implement telephone visits with patients so we can actually collect the data over the phone. Now, this certainly wasn't all the data that was needed, but it's kind of the best of a bad situation, and only bringing them into the hospital when it was deemed absolutely necessary to conduct assessments. I mean, in terms of thinking outside the box, sometimes if they had to come in for to have bloods taken, we would arrange with their GP to take the bloods instead, so they'd have bloods taken locally, so they don't actually have to come into the hospital. And I suppose our main aim as clinical research nurses was to really try and make the patients feel safe, that we wouldn't put them in undue danger by asking them to come into the hospital. The fact that we were actually collecting data via the telephone meant that we had to change the data collection process, where they would normally come into the hospital and we'd collect real life data from them. We were now collecting it via the telephone, so that was a whole new change to the protocol, because we were collecting data in a different way. So, our main aim was to actually retain the patients rather than, them actually wishing to discontinue with the study. And when the full lockdown regulations came into effect, what we found was that for active studies where we were actively recruiting, patients just didn't want to come into clinical trials. And again, this is quite understandable. Patients, were reluctant to put themselves in a position where they'd have to come in for assessments and blood tests if it wasn't necessary. And in fact, the HPRA issued guidance on the management of clinical trials. And in that, they actually acknowledged that it may be necessary to actually suspend recruitment. And I think across most of the state of Ireland, that's what happened with clinical trials. The majority of them actually suspended recruitment. And in one extent, it was an opportunity for us to focus on patients that we already had in studies and retain them. But on the other hand, if you look at it from, a sponsor perspective, a global suspension of clinical trials puts an added pressure on the recruitment timelines, which then has an added pressure on data analysis. And actually, it can actually delay by months or even years bringing a product to market and getting approval. So it has huge financial implications for sponsors, but also from a side perspective, if we're not recruiting patients, we're not actually getting paid. That has an implication for resourcing and staffing in the long run as well. Many of these studies may not actually get up and running again. And as we actually found, although we've actually opened recruitment again, patients are very slow and very reluctant to take part in studies. So certainly the recruitment rate has been impacted by COVID as well. So, we're way behind, our recruitment targets, and I think patients, personally, I think it's because patients are aware of, the recurrent waves, and they have this, anxiety that, if they start in a clinical trial and then we go into another lockdown, they'll have to come in. So it's understandable why, recruitment is very, very slow. And so that doesn't have, a long ongoing impact in terms of resourcing and staff, employment at sites. In terms of study medication, we had to implement a contingency plan to get study medication to patients where possible. So these would be patients that were taking oral medication or self-administered medication, that we would have to actually get medication couried directly from the hospital site to the patient's home. This plan was actually put in place by the sponsor, but it was managed completely by the site staff because of data protection. We had to ensure that no patient data was actually sent to the sponsor. But it meant that we had to implement mechanisms where, the drug was delivered to site and then sent straight out to the patient. Patients were taking the drugs according to as it was prescribed. It meant that we didn't do drug accountability as often as we'd like, so we had to rely on patients taking medication as prescribed as well. But it meant that there was further changes to the protocol because of this, and then consenting patients to get their permission to send drug out to them. So all of these things, added training for research nurses, added administration, added paperwork as well. And in addition to that, I suppose there were because the borders were closed, there were disruptions and delays in supply chain. So that actually impacted on biological samples that were being sent to central labs in Europe, particularly samples that are sent on dry ice, frozen. So there was often a delay in the delivery of dry ice, so we couldn't send these samples off. And these samples are time sensitive, that they need to be sent off within 24 hours on dry ice. Often it meant that we'd actually have to retain the samples at site in our own freezers until we got the delivery of dry ice. So it meant we were then responsible for samples that should really have been shipped away. So added documentation from a site perspective to manage and maintain the temperature of these samples at site, to maintain their integrity before they've been sent off to the central labs for analysis. And all these changes required changes to the protocol, which were necessary because there was a clinical trial, changes to the trial methodology, changes to data collection, and changes to recruitment timelines meant that numerous amendments had to be submitted to the ethics committee for approval. And then following approval, it meant that patients had to be reconsented to the changes as well. So again, there was a lot of administration involved in that, a lot of reconsenting of patients before these procedures could be carried out as well. And I think to their credit, both the ethics committees and the HPRA certainly prioritised ongoing studies where amendments would be submitted, and also COVID-related studies. So it meant we were able, through this collaboration, we're able to actually get these amendments in place quite quickly. And I suppose what we have learned learned from that is that, oftentimes it can take an awful long time to get a study from the startup period to actually actively open as a site. And I think also Ireland has a reputation of being very much a delay in actually getting studies up and running. But we've actually seen during COVID, we can actually get studies through a lot quicker than we previously thought. So it is possible to get things, get studies up, running, and actually actively recruiting in a much shorter time frame. And as I mentioned before, all the changes to protocols meant there's a lot of training for staff. And that meant that, there was a lot of online training for staff. There's a lot of staff meetings via Zoom, so that all the new information can actually be disseminated to staff members as well. And you have to remember, due to social distancing, staff were often working opposite shift to each other, just so that there was adequate space for social distancing. So it meant that, certainly in terms of managing a clinical research team, you had to make sure that everybody had the appropriate training before actually conducting any study activities in relation to the changes. And in terms of sponsor oversight, so the sponsor responsibility is to ensure that the clinical trial has been conducted in compliance with both the protocol and with European and national regulations. And due to the restrictions on visitors to hospitals, it meant that sponsor representatives couldn't attend the site. So it meant that monitoring visits were conducted remotely with the sponsor representative. But it also meant additional pressures to nurses, because documents that would have been collected by the sponsor at on-site visits now had to be located in the files, scanned by research nurses and emailed to the sponsors for their review. So again, it was additional administration for the site staff. And I suppose just one thing to add is that the additional work that we have, we weren't being paid for. So the budget for clinical trials are agreed upon during the startup phase. And I suppose one thing to note is that all the additional work that we've had to do, we've done obviously because it's necessary and to continue the clinical trials and maintain the safety and well-being of the patients, but we're not actually paid for the additional work as well. So that's one thing I suppose to note as well. And I suppose really, by mid-June, by mid-May, we had kind of, I suppose, got used to the new normal, as it's been called. And we were kind of like, I suppose, getting used to running clinical trials in the middle of the pandemic. And I suppose then the cyber attack hit us then, which was another blow. And from a research perspective, it impacted us in terms of our ability to access patient patient notes, patient booking outpatient appointments for patients, accessing procedures, so booking x-rays and ultrasounds of patients. There was a lot of delay. Priority was given to urgent cases. So it often meant that procedures such as x-rays were done outside the visit window for the protocol, which was then seen as a protocol deviation. Accessing external databases was a huge issue. Many of the clinical trial data is actually entered electronically onto case report forms. These are external websites, databases maintained by the sponsor. Access to external databases and websites wasn't available during the cyber attack, and often it needed research nurses to bring in their own laptops from home to actually be able to use and access these databases. The Wi-Fi was often very poor during this time, so often I personally use my own mobile phone as a hotspot, so I could use my laptop to actually enter data, clinical trial data. So I suppose in terms of thinking outside the box, this is what we had to do to get the data entered in a timely manner. And I think really, I suppose, just as a round-off, what did we learn from this? I suppose what we found is that, as has been said before, clinical research has become more visible, but particularly as research nurses, there's always been, I suppose, a misunderstanding that research nurses are not clinical, that we're in an office and we do a lot of administrative work. We don't really have any hands-on experience with the patients. I think the visibility of research nurses on the wards recruiting sick patients for COVID studies has given a visibility that actually we do have clinical skills. We are involved in the management of patients as well. And I think the actual involvement of research nurses in getting COVID-related studies up and running and actively recruiting can't be ignored. It's shown that we have a can-do attitude. We're very good at problem solving. And I think also, it's shown that there can be collaboration across the board, with our colleagues within the clinical area as well. I suppose one of the negative points I found is that research nurses, less than a quarter of research nurses are employed by the HSE. So we're not often counted in the numbers. So issues like access to PPE, that was a problem in terms, certainly for myself, trying to access PPE, because the hospital didn't count research nurses in the numbers. So, there was a process where, we had to apply, had to get access to the PPE rather than actually it just being available to us automatically. So I think, although integration of research into the health service has started, I think certainly there's more that needs to be done so that there's more awareness and we're kind of seen as part of the workforce as opposed to something external. So, thank you.
That's great. Thank you, Carole, so much for explaining that in such detail. It's really comprehensive. And just to see the various challenges from, team membership and managing the team, new training, new protocols, all of the administrative burden, the lack of access to PP, all of those issues. But we've been talking about, and you mentioned it too, the raising the visibility of the research nurse. And we've talked about how the pandemic has raised awareness of the importance of health research. So I suppose I just wanted to ask you if you feel now, after all that you and your colleagues have gone through and contributed, do you think that there's a greater appreciation now, or that there is more support for research nurses, an acknowledgement of the work, the important work that you do?
There's an acknowledgement, definitely. I think certainly, because we're visible on the wards with the COVID studies, so there's definitely an acknowledgement and an awareness of us. I think we need to work on that so we don't lose that visibility again, once, if this ever dies down again, that we're not just resign back to the clinical research facilities or back to our research departments. I think we just need to use this opportunity to say, we are here. But I think, integration into the HSE infrastructure as a whole will help in terms of supporting research nurses.
That sounds great. Definitely go forward. So thanks very much, Carole. I'd like to move now to our second speaker. And today we are joined by Professor Peter Beresford, who is a OBE, who is a service user activist. He's visiting professor at the University of East Anglia and co-chair of Shaping Our Lives, which is the National Disabled Peoples and Service Users Organisation and Network. He's a long-term user of mental health services and has a long-standing background in involvement in issues of participation as a writer, as a researcher, as an activist, and as a teacher. He's co-editor of Madness, Violence and Power, a critical collection, and also co-editor of the Routledge International Handbook of Mad Studies. And I'm very much looking forward to listening to Peter today. So I'll hand over to you, Peter.
Thank you, Lisa. It's really good to be here. And I've already been told I can count myself as being in Ireland, which is a breath of fresh air, to be honest. So just very quickly to start off, as you've heard, I'm a survivor researcher, as I identify. The major impact for me of COVID was basically losing my job. So I was appointed at a UK university to be their first professor of citizen participation on a 4-year contract. It was lovely working there, lovely colleagues. And then towards the end, COVID came and they desperately wanted to cut costs. And I was one of those costs. And they said in my appeal response, and I lost my appeal, of course, that due to my brilliant work, they'd so far advanced on citizen participation in the school that they really didn't need me anymore. And that literally, and so that my colleagues, none of whom identified as disabled, would be able to carry on that work. The amazing thing was that another university involved in the same research project, which I had brought to that university with funding, then decided to pick me up and give me a job as well, very part-time jobs, but I am so grateful. And I think that sums up really for me life generally in these difficult times, perhaps also issues around COVID, which I want to elaborate on, which is the difference between formal structures, formal politics, personal politics, and how people behave to each other. And how people behave to each other so often in positive and helpful ways. I mean, we have to remember, getting back to what's really significant here, that in the UK, well over 100,000 people have died, that the people who've most died and most suffered in COVID terms have been disabled people. That's the evidence. And we know also that very many people were arbitrarily exported from our NHS to social care and then died in very large numbers, also incurring deaths among many care workers. The reality is that for much, I think, perhaps it's begun to change, but for much of the COVID period in the UK, true to say, what we've come to call PPI, public patient involvement, was put on hold. Wonderful developments. We've had wonderful developments getting us to where we are, but it was, I think there was really a kind of an unspoken attitude of, hang on, this is a medical emergency, we cannot waste time, and involving people would be wasting time. I think what you would hear from people as patients and service users, as disabled people, as mental health services users, as people with palliative care needs and so on, would be, if ever there were a time when you would need to have the lived experience, the experiential knowledge of people as service users, of course it would be in a medical emergency like this, but particularly in relation both to COVID itself and the policy response, which critically was about lockdown, isolation, and people being subjected to very different physical and psychological conditions than most were used to, but not many people as service users who were incredibly used for both personal mobility issues, but also the way that transport and other things work in our society, to being constrained, living within four walls, sometimes being in a bed, not being able to go out, having to deal with isolation, having to find ways of making contact, having to find ways of dealing with and understanding their situation as people perhaps lacking energy, lacking strength, facing pain, and so on and so forth. All the things which, of course, especially in the context of long COVID, we've realized we really need to grapple with. My first insight into COVID was that one of my colleagues very early on obviously got COVID, and what was his symptom that was most important to him, he recovered after a quick time, was he couldn't taste or smell anything. That wasn't mentioned, and we had a very kind of monolithic view of what COVID was like, which of course, as the evidence has emerged, particularly the lived experience of service users and patients, we've come to understand differently. So I think this is really significant and something to consider as to challenge for the longer term, for what Carole, you called the new normal, what people call the new normal, that we do not just think if things get different or more difficult that we put really positive developments like involving people on hold. But I would want to make a distinction between what's called PPI, formal PPI, and the user involvement that many people as patients and service users demand and want and press for and have achieved. They aren't quite the same thing. PPI often means, in quite consumerist terms, being listened to so that the system can adjust itself. What people want user involvement for is to have much more say over their lives, the services, the policies that impact on them. Those are two quite different things. And I think it's been particularly that people as service users and patients we have kept going, and I'll come back to that. But what's interesting in the UK as well, of course, I'm talking about Westminster government, is the way we suddenly had a whole alliance, an unconsidered and unrealized alliance with traditional science, because many of our politicians were listening as little to traditional science as they were listening to the new ideas, new ways of thinking about knowledge and generating knowledge and what should count as knowledge, which people as what is called lay people or service users were developing. And I think we shouldn't forget that. And I think there's something there for the future around building alliances. And I think that's something, hopefully, listening to the perspectives that I think are around today in Ireland in this event, which will make sense to you. But I think a difference was highlighted again for me between institutionally led PPI and citizen-led user involvement. We've had to fight to get listened to. And I want just very briefly to talk about an initiative that a group of us made. I was approached by a publisher, Policy Press, which is an academic but charitably based publisher in the UK, a major publisher of social policy publications, and they wanted something in a new series they had, particularly influenced by COVID, of getting things out there, getting knowledge out there quickly. And what we were able to do was put together a group of us, including service users, a group diverse in terms of gender and ethnicity too, and experience, to put together a book. That was the plan, about COVID and co-production. That was the plan. Well, it did kind of grow, and it ended up by being two books, one effectively about what was going on now, the barriers, the problems, and the second one, which drew on international experience to looking at what we could do, what we already were doing, or the possibilities. And I really would recommend people obtain these books. There's nothing in it for us because they are open access. They are for free from Policy Press, and they are called COVID-19 and Co-Production in Health and Social Care, Research, Policy and Practice. And I really think it's helpful. Over 100 different contributors took part in those two books at the end of the day. And I think that really highlights the importance and the value of drawing in a wide range of diverse identities and experience. So we focused on the problems, but we also focused on what was going on and what could go on to overcome the problems. I think what the lesson I've learned from this, as I've learned from much of my involvement, is the value of building from the bottom, the value for all of us of understanding and appreciating all of who we are in its complexity. And I say that as a service user, you know, having to get to know yourself to deal with the difficulties you face. But I think it's so valuable also for researchers who don't identify as I do, and clinicians, people who are working in the field, people like the nurses that Carole talked about. One of our daughters is such a nurse who's both a researcher and also a clinician. That you can think that what you bring to bear isn't just your formal training, what you've learned from the courses and the books, but all of who you are. And I think that builds the kind of equal relationship that's so important here, which service users so much value. That helps also to change the relationship that research can have with practice, with human beings, with the difficulties we encounter, and also I think with policymakers, because I have learned from experience, because it can happen to them, that one of the few things that gets through to some politicians and policymakers is lived experience, which they can also, perhaps in their own lives, identify with, rather than being talked at, as they might see it, by people that they are approached by as experts. We are all these things, and I think we should make the most of all that we are. And I hope that can be of some help. The UK experience, of course, is not unique, and I know of people and have worked with people all over the world, I'm proud to say, including Ireland, with those same hopes and aspirations. It's the way to go. As I say to people in my less careful moments, I do feel these developments are on the side of the angels. It may feel difficult, but ultimately I do have that kind of optimism that's been mentioned. However difficult UK politics might seem to us in the here and now, things are going to get better. Thank you.
Thank you, Peter, so much. I think your optimism is inspiring, and I think there's a lot to learn from everything you said. I see in the chat people have asked about a link for the book, and I think Carole, our colleagues, have popped that in there. So if anybody's interested, the links to those are in the chat box. Peter, just to follow up, I'm really interested in, well, obviously what you were saying about budding alliances. So I wouldn't mind if you just expanded on that a little bit, and what you think could be done to grow those. But also you touched on the piece about policymakers, and that's an area in Ireland that there's a lot of focus now turning, with our new Department of Higher Education and Research coming together and really trying to look at ways that we can make sure that evidence informs policy making. And I suppose you were talking about, policymakers' lived experience that they can identify with. I don't know if you have any examples of you engaging at that level, or any suggestions or directions you would like to point us in, because I think it's something that's critically important. And it's about bringing all of the players in, the researchers, but the policymakers and the public and the citizen throughout. So perhaps you'd like to comment on that.
There's a lot to comment on. I've been fortunate, not recently, perhaps for obvious reason in relation to the kinds of politics we have, but historically I've been fortunate to be involved at a high level in minister-led initiatives around involvement, around the workforce, around services, around service development, around education. The involvement that I was most proud of being part of alongside other people was the change which we actually brought about because of the preparedness and the listening of people at a high level, so that, and I don't know the situation in the Republic, that now in social work education in the UK, both qualifying and post-qualifying, there is a requirement for user and care involvement at every stage, at every level. And also, actually, it still is a central government budget. It's about £8,000, not enough, but something to support that. And I know that both students and people working in universities in those courses find it transformatory in its implication. And some of that pressure has moved also into allied health courses where there's not the funding, but there are the requirements. And I think that's wonderful. And I think that was brought about through the kind of understanding of high level, I suppose what you'd call civil servants, who were listened to because they had traditional clout as well as being sensitive to these issues. But I think that, I mean, the particular person I'm thinking of, I think the reason why she, as I would put it, got it was because she was a woman who I think would identify as coming from the women's movement, who had a broader understanding, and it's those sorts of alliances. I've been terribly taken in the killing in England of I think her name, I'm not good at names when I'm under pressure, is it Sarah Everard, who was murdered by a policeman, and I've had to think about it because I thought it was so consequential. And when you look at that awful event and you look at the chains of linkage in terms of what was done to her, but also in the resistance and response from women and women's organisations and others to it, I think you have hope that the divisions that there are between us and the politics that rule our lives can be challenged. We've seen it with Me Too, and we've seen it with Black Lives Matter. And I think those are the same things that we as disabled people, as service users, are working on. And I think where we appreciate and are inclusive about the complexity of our identities, we are not just white service users and so on and so on. We are not just men. Then we begin to recognize and hopefully will give more priority to the issue of building alliances between our different overlapping movements, because they are overlapping movements. And if you add us all up together, I think we make up a formidable proportion of the populations.
That's great, Peter. Thanks so much for your insights there. I'd now like to turn to our third speaker, Mairead, Dr. Mairead O'Driscoll, who's Chief Executive Officer of the Health Research Board, which is the lead agency in Ireland for health research. Before being appointed as CEO, Mairead held a number of other senior roles in the HRB, including Director of Research, Strategy and Funding, with responsibility for a budget of approximately 40 million a year and an awards portfolio in excess of 150 million. Mairead was also head of policy evaluation and external relations, and she worked as a researcher in academia and industry before moving into policy research. She was with the Royal Society in London and then with the Wellcome Trust. And she's also spent some time, which I wasn't aware of, Mairead, in South Africa, where she worked on the development of a national research and technology foresight study. She's a member of numerous national and international groups and is a graduate of Trinity College Dublin and University of London. So I'm going to hand over to Mairead now. Thanks.
Thanks very much indeed, Lisa, and thanks to Avril and the IHRF for inviting me. This is a great discussion, I have to say. Just to set the scene, I suppose, for you, the HRB is the main funder in Ireland of health research. So in terms of our community and who makes up our community, it is, of course, health and social care researchers. And I think, as Carole set out very eloquently, many people in our community were impacted because, of course, their research setting is a healthcare delivery setting, or if it isn't, then they're working with people in those settings. And we've heard about the day-to-day impact on that, particularly in the areas of, any sort of patient focused research. Clinical trial recruitment were all badly affected, but also things like longitudinal studies where people had to get out into the field and collect data, survey data, and so on. All of that was impacted. The other thing, I suppose, about the community that we serve is that it includes a lot of health professionals, and because of their health professional role, or perhaps a previous qualification, many were reassigned to clinical work during the pandemic. So a lot of people were taken off research or away from research, I suppose, and reassigned to other duties. So I suppose if you put all that together, COVID really had a very significant impact on a lot of the work that we would fund. And I think that context is important because, of course, people's careers and their research is affected very often by things that are completely beyond their control. The other feature of our community is that it is quite female. So we support a lot of women. It's just the nature of of health research, I suppose, and the nature of the health and social care system. And we know from information at a global level that the impact on women has been disproportionate because women do tend to take on the bulk of care responsibilities. I know lots of men do that too and are taking on more than perhaps in the past, but still, probably it's fair to say the bulk tends to fall on women in terms of additional caring responsibilities and homeschooling duties. And that's a theme that has been, I think, discussed in many fora. There was the Oireachtas debate on International Women's Day this year. In April, we had the European Gender Summit. And it was a theme in the Global Research Council as well during the year. So a lot of work has been done on this, and it's actually fairly consistent, in the sense that data collected across sectors has shown that women were more negatively impacted. So in terms of how the HRB responded, of course, we had to take on a lot of COVID-related work around supporting the Department of Evidence, supporting COVID-specific trials and research, supporting the COVID Data Hub, setting up the COVID Biobank, so just to name a few. So a lot of specific COVID work, I suppose, came our way, but that's perhaps a subject for another discussion. I suppose in terms of our funded community and the people who have awards from us, you could frame our response in terms of short or medium-term actions. And I suppose then we have to think about the longer term as well. So in the short term, we considered, I suppose, who might be applying. We certainly looked at things like extending deadlines as far as we could. We, considered a lot of people who would be involved in multiple funding applications and just their capacity really to engage with all of that. So, it just so happens that at the time that all this hit, we were in the process of embarking on some significant investment in clinical trial networks, in facilities, in other forms of support for clinical research, and that's just where we were in our funding cycle. So a lot of the people who would be applying for one might also be involved in another. So we certainly had very at a practical level adjusted timeframes and so on to accommodate applicants, and talk to people about what their preference was in terms of changing deadlines. I think that's kind of relatively sort of, I wouldn't say easy, but it's, that stuff you can put in place. I think in the medium term, we have to start to consider those gaps in productivity for individuals and how we can take that into account in, what is, getting research funding is incredibly competitive. But in fact, this is part of, I suppose, a move more broadly that's going on internationally. There's a more holistic view being taken of assessing applicants' experience and expertise, and that's in line with the DORA declaration, which is all about looking at better ways of assessing research. And certainly we had already started to look at other metrics for assessing applications, allowing for career breaks, for example. And I think the disruption due to COVID is something that is going to, it's a kind of a prompt, I suppose, for a further prompt in that direction. And it's something that's going to have to be included, I think, for some time in the way we work. What did we learn? First of all, not everybody is affected in the same way, and the impact on one project can be much more significant than on another, even if it's the same researcher. So that the nature of the research mattered in terms of the impact. And of course, health research itself is made up of many different areas and fields and disciplines and methodologies and so on. And there's no doubt that people in certain disciplines or people working in healthcare settings were definitely more affected. I think we also learned that we as an agency, and not ourselves as an agency, and the research community that we work with needed to be able to pivot. We needed, and the mention was made there, Peter mentioned, collaborations and networking and so on, and that's absolutely key in terms of supporting researchers around delivering work, but also accommodating people who just can't deliver to the same sorts of timelines. And I think also Carole mentioned there the integration of the clinical research infrastructures into the health system, and that's something that even before COVID we were looking to do. How could we incentivize that co-investment, co-partnership? It's not just, by the way, about the funding. It's also just about embedding something and taking ownership of something in a health system. So I think we could see again the real importance of that, and I think COVID may have catalyzed even for more or faster changes in that direction. And I suppose the last two things just to say is that communication is absolutely key. I mean, communication with our research community in terms of where they're having difficulties. And what will work for them, and on the other side as well, communication with our panels and our viewers, because there's a whole community out there who we work with, to assess awards and to help us to make the right decisions. So keeping those opening up those lines of communication and making sure that they're effective, I think was really important. And then just the last thing I think was around flexibility and just understanding was also absolutely crucial. Just understanding the context that people are working in, the issues that they're dealing with, and that's been absolutely key. So I think I'll stop at that point, Lisa, and hand back to you.
That's great, Mairead, and thanks very much. And just to commend the HRB for the way that you work so closely with the research community and with patients and the public during the pandemic to really embrace that and to work collectively as we were faced with those times. I'm conscious of time. I do want to ask you a specific question, Mairead, and then I might open it up just to one question to the panel. So just you talked a lot about the impact on female researchers in it, and also the the medium to long term. So perhaps a brief comment on the ways that we could, what HRB is thinking about, because, in 5 years' time or 10 years' time, a female's track record is going to be affected, but it's hard to say, so what can we do for that? And then more broadly, just so the panels can think about it, because I'll stop talking, is that, if we were faced with another pandemic, would PPI, would citizen engagement be to the fore? What would your thoughts be to prepare us for that going forward? So, Mairead, I'll hand over to you first, and then ask Peter and Carole to comment.
Okay, I think yes. In terms of sort of, we've been looking at this, and there's no easy answer to it actually, which is around metrics. But I mean, a lot of it is around just that whole very traditional way where you just kind of look at publications and it's sort of very chronological sort of track record. I think we're really having to move away from that, to look more at people, I suppose to ignore, or not even just ignore, but to find ways of taking away the gaps, I suppose, and looking really at people's best publications, not necessarily numerical counts and so on, and also looking at other metrics. We've been kind of trying to move away more towards a sort of a more narrative-based approach when it comes to assessment. So asking people, to just, I suppose, describe the contributions that they have made. We've also moved more towards looking at things that I'd better be careful now not to make gendered comments, but things that perhaps maybe different people have focused on more, which would be around sort of things like the whole PPI, public involvement, other things that people are doing, dissemination, broader metrics for around dissemination. So in other words, just taking a much more holistic approach, I think, to somebody's research career, rather than a very narrow, how many publications have you got and what's the citation impact and all of that. So that's really the direction of travel, I think, for all of that.
Which leads us nicely into maybe the other members of the panel just commenting on the future of citizen engagement, and if we were faced with another pandemic, before we close for our comfort break in a couple of minutes.
Hi, I suppose from my perspective, I think that, I know this is called the new normal, but I think this is just the way things are. And I think certainly from a research nurse perspective, we've made changes so we can manage clinical trials during a pandemic. And I think for the foreseeable, this is just the way things are. So I think we'll be ready for another wave and the wave after that. Because I think this is just the way things are going to be. So I think we've kind of resigned ourselves to always being prepared, always being in fight mode almost, And I think, as I said before, we've kind of made the initial steps in terms of making ourselves more visible. So I think we should, use this as an opportunity to further kind of, entrench ourselves within the health service as much as we can. So certainly for things like PPE, we're established now that we need to have PPE as well. So we'll just build on that.
That's great. And I might hand over the last word to Peter, if that's all right, given that we need a moment of comfort before the next panel session. So Peter.
I think also that I was reading yesterday that there are an increasing range of biotics that are resistant to antibiotics, and it's becoming more and more troubling. And I think we're going to have to move out of this assumption that seems to be creeping in under our present politics and policy making, that we can actually go ahead with a notion of, we're just going to have to tolerate pandemic after pandemic. No, we've got to deal with why there are pandemics. And pandemics, we can't always be sure, and we still aren't in relation to this one, what are the actual origins, but they are to do with problems of a human making. And how humans can behave now, and also the responses to them. We've seen such differences between different societies. We have the UK and America, where it's been utterly catastrophic and not unconnected to the overall politics. We've had other countries like Taiwan and South Korea, for example, or New Zealand, where it's been totally different. And so this isn't actually an act of God. There isn't something inevitable about it. And more to the point, we do need to build that connection between our personal politics and the politics that guide us. And I think that was very, very evident in Glasgow last week. And I don't know really how they get so separated, but they seem to do. Everything seems to have run a bit awry, and I think we need to challenge that. And we have to build from the bottom. And the first thing I'd want to stress is it's appropriate in one sense to talk about the new normal, but when we've had discussions in and beyond shaping our lives about the changes that have been taking place, which affect everyone, including us, people have highlighted that some of the things about the old normal were not very helpful for disabled people and other service users. And some of the things about the new normal are quite helpful, and others not very helpful. I mean, we live with what's rightly recognised as a digital divide, and that's really damaging, of course, to many people who were not signed up for one reason or another, including in England, parts where you cannot easily access, even if you have the personal resources, reliable internet. All these things need to be addressed. But we must, I think, stop talking about involvement and talk about inclusive involvement. We did a big project which our Department of Health funded. And again, if you look on the website of Shaping Our Lives, you can see the reports called Beyond the Usual Suspects, how we break down the barriers of who gets left out. So we wanted to find out who got left out of participatory initiatives and what would work at a local level to try and make sure that they weren't left out anymore. And even beyond the sort of recognized characteristics around gender, ethnicity and so on, there are many other groups of people who get left out routinely, and we need to address that. And if we don't do that, then when we talk about involvement, again, we're only talking about some people's involvement, and it could be that it's the least privileged who are least likely to be involved in the participatory arrangements. So that should be part of our new normal thinking, I think, whatever we call it, don't like that term, which is that we take the best from the past and the best from what we've been having to learn, and we try and experiment together to make that which is most inclusive for everybody. And that, I think that's the way to go.
That's great, Peter. And on those wise words, I would like to thank Mairead, Carole and Peter for an excellent session.